I'm going to welcome my colleague Uchu to the podium. I've had the pleasure of working with Uchu in advising NHS England on IF services now for the last couple of years. Uchu is a relatively rare beast. She is a consultant pharmacist. There aren't very many consultant pharmacists in the intestinal rehabilitation unit, or the IF unit, of London North West University Healthcare, which is basically St. Mark's. Uchu qualified as a pharmacist in 2007. She initially gained a lot of experience in pharmaceutical management across a variety of diseases, but she specialised in gastroenterology at the Royal London Hospital, and in 2016 she took over management of the pharmacy service at St. Mark's Hospital, which, as you know, is a national bowel hospital in London. Under her leadership, the pharmacy service expanded significantly, which is in itself no small feat these days in hospital medicine, with specialist teams specifically in relation to IBD, home care, management of liver disease and colorectal surgery. Since 2020, though, Uchu has been particularly focused on intestinal failure and intestinal rehabilitation and nutrition. She's become very active in this field nationally and internationally. And as I've said, I think my main involvement in Uchu, or with Uchu, has been in advising NHS England into trying to improve IF services for patients. Between 2013 and 20, she was a member of the UK Clinical Pharmacy Association's Hepatology and Gastroenterology Group and has been heavily involved in new drug appraisals for NICE. She served on the British Pharmaceutical Nutrition Group from 2019 to 2023, leading electronic initiatives, so she has a lot of experience, specifically of pharmacological management of bowel problems, and she is honorary lecturer at Hertfordshire University in the Department of Clinical, Pharmaceutical and Biological Sciences since 2016. So Uchu, you're going to set us up for lunch by telling us why medication matters. And I have to tell you, as a surgeon, the reason I became a surgeon, because I was terrible at pharmaceutical. I could never remember the doses of any of the drugs, and I got so sick of looking them up in BNF, I thought in the end, bugger it, I'll be a surgeon. I don't have to bother about that kind of stuff anymore. So Uchu, come and join us.
Do you know what? A lot of our doctors don't remember the doses. They just turn to the pharmacist and say, what's the dose? If you'd had a good pharmacist back then, who knows? Who knows? You'd have gone into a different field. Thank you for the introduction. I've already been introduced, so let's get on to see what we're doing today. So what I've tried to do is I've tried to make this very focused on yourselves as patients, and I'll give you a little bit of hints and tips to help you. So we're going to do a little bit of pharmacokinetics. Don't be scared. I'll break this down so it's very understandable and very user-friendly for you. Just to go through what is it, why is it important for patients, and just go through why we use different routes to administer medication, especially for patients who have stomas. We'll go through some classifications of medicines, prescription only, go through some prescription costs and give you some hints and tips on how you potentially could save money with that, and just to go run through a little some over-the-counter medications, and again give you some hints and tips on if you're procuring or using those, and then we'll just go through some medication in pregnancy and breastfeeding. Where to find information. So I normally bring a fluffy bowel with me. I brought it last year. And this is designed to help visualize the length of the GI tract. But it was last used to train our junior pharmacists and their leader, who's at the front. And so it was in a different hospital, so I didn't bring it today. But as you can see, just by put these photographs in, just to demonstrate the length of the bowel here. So it starts here with your mouth, you go into your duodenum, your stomach, and then you go into the first part of your small bowel, which is about 20 to 25 centimetres. And then you go into the next part of your small bowel, which is your jejunum, which is approximately 2.5 metres long. And then you go to your ileum or your ileum, which is the last part of your small bowel, which is approximately 3 metres long. So if you look at all our lovely junior pharmacists, the small bowel ends about there. So it's incredibly long. And then You end with your colon. I took a view from both sides. And your colon starts here and ends. So only two pharmacists were needed to hold the colon, and that's about 1 meter long. So you can kind of see the length of the bowel that we're talking about. But in patients who have had bowel operations or bowel surgery, that length becomes reduced, which will affect your absorption of nutrients, water, vitamins, just as Gordon says. But one thing that I'm very passionate about is that we should change the definition of intestinal failure to include the absorption of drugs as well. But I'll make my case, and by the end of it, you can tell me whether you think I'm correct or not. So to start a little bit about pharmacokinetics, this is the movement of medications within the body. It comes from a Greek word. And all medications are designed to target a certain cell or receptor within the body. But in order to get a pharmaceutical response from that drug, you need to have a sufficient amount of that active medication reaching the site of action or the target receptors. But in some cases, these sites of action or target receptors are found in the GI tract, but the vast majority of time, those sites of action or target receptors are found throughout the body. And so this is a little bit more about the flow of pharmacokinetics. In order to have a drug absorbed from your GI tract, you first need to have liberation. So if you think about the medication you take on a regular basis, they either come in tablet or capsule form. And you have within that your active medication or the drug that will become the active medication encased. So that solid formulation needs to break up and then liberate the medication and then form a solution that can then be absorbed from the GI tract. So that's the liberation stage. And then that solution is then, when the drug is in solution, it's then absorbed from your GI tract. It then is distributed throughout your body, and hopefully it hits the site where it produces its pharmaceutical response. And then it's metabolized mainly in your liver, and then it's excreted. And the majority of drugs, it's excreted in your kidneys. So for us, the most important part of this process of pharmacokinetics is really the absorption. Because, as you saw about the length of that bowel, the vast majority of drug absorption happens in your small bowel. And if you don't have an adequate small bowel, whether it be too short or it's damaged by disease or it doesn't get enough blood supply, then your absorption of medication can be impaired. So I think it's important to try to explain that to not only healthcare professionals, but also patients as well. So you can kind of understand if we alter your drug doses, why we're doing so. As I said, the most common forms of medications that are developed around the world are oral formulations, so tablets, capsules, and liquids. So they need absorption. As I said, the first part of the bowel is where it's mainly absorbed from. But the absorptive capacity, which I've talked about as well. Again, I've gone ahead of myself. There you are. One of the concepts to introduce is something called oral bioavailability. And this is the amount of medication that is absorbed into your bloodstream after you've taken a medication orally. And every single drug will have an oral bioavailability, and that goes from a scale of 100% being absorbed to nothing in some drug cases. But all of these studies were based on healthy individuals. So I'm introducing the concept now, but hold on to it because later on it will become more important in the talk. So this is another tool just to help us visualize. So if you take something orally, it goes into the gut and then is absorbed into the plasma, and then from there it goes to the sites or the receptors where you need to elicit that pharmaceutical response. So for the reason why it's been prescribed. And again, hopefully this diagram will help you. You have some medications that if it's administered orally, it will then go into the gut, and that's where you'll see the action because the sites are in the gut. So why is it important for patients with pouch? So for yourselves, you need to make sure that we're getting good oral bioavailability. So that means that we need to make sure that there is a good amount of that drug being absorbed. We need to make sure that we're getting enough medication reaching the systemic circulation, so it can be distributed out to all of those receptors around your body in order to receive your pharmaceutical response. So for yourselves, I would just be very cautious if you're ever prescribed something that is modified release, that's designed to release in your colon, or designed to release in a certain area of your bowel, because that might not work for you, simply because your bowel anatomy has been altered. You need to be careful of anything that's extended release, controlled release, or modified release formulations. So if anybody tries to prescribe you anything that has an extended release profile or a modified release profile, just be very cautious of that. But I've got some tips. And this is why it's important to explain your GI anatomy to anybody prescribing you medication. So you can either say to them, that I have a, and then describe what you have. So you don't need to know your GI anatomy, but you just need to make them aware that to take your altered GI anatomy into consideration. Or you can ask them to look at your records or to contact any teams that are looking after you, because they'll be able to give them further details just to make sure anything that's prescribed for you will work for you. And your healthcare professionals, when they know this information, they can really adapt and tailor your medication regimens to you. And when I'm talking about medication regimens, as a nation, we're all living with more long-term conditions. Also, you might get acutely unwell, so then those acute conditions need to be managed. And then also you might have complications for the reasons why you have a pouch or you have altered anatomy. So all of that. So there's lots of prescribing that happens for our for this patient cohort, and we just need to make sure that everything is being monitored correctly. But if the prescribers don't know to monitor you in a different way, then that can't be done. So we might prescribe a higher dose than is recommended for people without altered GI anatomy, but then we need to monitor that closely. We might have shorter or longer durations before we give you the next dose to help. We might give you alternative routes. Again, back to this diagram, and this gives you all of the different alternative routes that we can have. And if you see here, if we go intravenously, we're going straight into the plasma. So we're avoiding having to use the gut, intramuscular to the muscular, and then to the plasma. And those are the main ones that we'll use. And percutaneous, which is like subcut underneath the skin, directly into the plasma. So there are different routes that you can use to avoid the gut if needed. But if your doctors or your prescribers don't know, then they don't know to make that amendment. So we'll just go through some classifications of medications now. Prescription-only medications, they can only be prescribed by healthcare professionals with the relevant qualifications. Codeine and loperamide, I believe the vast majority of you might be aware of those or be using them yourself at the moment. How do they work? This is a great example of medication that works in receptors in the gut. So they work in receptors in the gut. They're called opiate receptors, and they act to reduce the motion of your bowel, allowing more time for contact with ingested matter in your bowel, and allow more time for absorption. This results in a reduced bowel frequency and quantity, and also can result in a thicker consistency of your stools or your stoma output. So with loperamide, we do go up to doses up to 16 milligrams 4 times a day. It's more favourable than codeine because it's less sedative, and it's got very little absorption from the GI tract. So a lot of it's not absorbed into your systemic circulation. And just to mention, I know in the past some of you might have tried a liquid preparation for loperamide, but that's no longer available. That's been discontinued in the UK. And then we have a drug called codeine, which we can go up to 30 to 60 milligrams 4 times a day. And exceeding or going above this dose shows no benefit, but gives you a lot of side effects. So we try to avoid going above that dose. It also can be used for pain relief, so could help if you've got a little bit of pain as well. But caution, because it can come in combination with paracetamol as well. in forms of cocodamol. So if you're prescribed codeine and somebody tries to prescribe you cocodamol, just make sure that they're aware you're already taking codeine. There's a lot of evidence to demonstrate that if you use loperamide and codeine in combination, they work synergistically and better to reduce your stoma outputs and thicken up the consistency as well. So how to take loperamide and codeine? Ideally to take it 30 minutes to 1 hour before your meals. This allows time for the drug to work before you eat and drink, so it will slow down your bowel before you eat or drink, so then allowing time for that absorption. The side effects need to be balanced, especially with the high doses of loperamide. Loperamide can cause abdominal pain, bloating, nausea, and flatulation. With codeine, drowsiness, headaches, low blood pressure, nausea and vomiting, and can cause dependence. So that's something that we just have to be very careful of and to monitor with our patients. And one of the things that if you stop codeine or if there's a period of time where you have to stop it abruptly, you can potentially get withdrawal symptoms from that. So we've just got to be careful. With loperamide, you might see on the boxes and all of the patient information leaflets that's produced, it says that you can't go above 16 milligrams in 24 hours. But that information is not for you. But if you're curious to see where that came from, it came from an MHRA drug safety update. And for those who don't know, the MHRA are our governing body who regulate medications in the UK. And that was released in 2017. It came out from a European review of worldwide spontaneous reports. And there were 19 case reports of cardiac arrhythmia disorders with loperamide abuse and misuse. And that caused when you look at your heart rate, and it comes out as a pattern like this called an ECG, there's a point called a QT interval, and they found that in patients who were using very high doses of loperamide, that was extended, so it could cause irregularities with their heartbeat, and ultimately to lead to cardiac arrest. So when this alert came out, I was on the ward doing my work, and I came back and I could feel my work phone vibrating in my pocket, but I was so busy I thought I'll deal with that when I get back to my desk. And when I got back to my desk, I kid you not, I had about 40 emails on this topic. What's St. Mark's doing? What are you going to do? Do we need to write a report about this? And then so what we have a medicines information department within our pharmacy team, so I asked them to write to the MHRA and ask for all of their data. And I expected really high quality data to come back to me, but there was just 19 case reports. And when we took a look into those 19 case reports, they were using very, very high doses, so 40 to 80 milligrams, or sometimes, and in a few cases, up to 800 milligrams. And loperamide, as you all know, comes in 2 milligram tablets. So because I wanted to teach one of my juniors how to critically appraise and review papers. So I roped her into doing this with me, and we just happened to be on her computer. So we Googled on our work computers, which is very foolish, how do you take 800 milligrams of loperamide? Oh, we went into a warren hole. There are whole forums designed on how to teach people how to abuse and misuse loperamide. But the one that we found that was most interesting is people were putting all of the tablets into a blender, making a smoothie or a shake, and then drinking it down. And then 2 days later, this junior pharmacist got an email from IT to ask her what she was doing on these sites. So I had to, as her line manager, write a formal letter back to IT and HR to say that she's not abusing loperamide, and please do not report her to our professional body. And the feedback from my line manager was, next time use your own login or your phone. So that was interesting. And again, it was abuse, and the main abuse that it was being used for was actually people trying to better themselves. It was people who were addicted to things like street drugs, street opioids, and they were using very high doses of loperamide to try to wean themselves off those street drugs, because it acts on very similar receptors. And what they found is, do you know, as I told you, that it's got very little absorption when it's taken orally. If you push those doses and give really, really high doses, it bypasses those mechanisms, and then you will increase the amount of absorption or the amount you have in your blood. And in that way, it distributes to all of those different cells that the street drugs would distribute to, and then they can use it to slowly help wean them down. And this is what I say every time I give this talk. We're actually really lucky. I know the NHS is a beast and can be problematic, but in this country, we're not seeing those levels of abuse. All of these case reports came from America because we have services that will help people come off or help them with their addiction, whereas they don't have that in a lot of parts of America. So as a result of all of this, and again we disagreed with it because it was only 19 case studies, it wasn't in the UK, and it's not a trend we were seeing in the UK at the time. All manufacturers of loperamide had to add that warning. And then one day, again, come back to my office, and I see Dr. Nightingale sat on Jeremy Nightingale, who sat on my couch in my office, and he's like, oh, I want to write something about loperamide to tell people in the gastro community that it's still safe to use. And I said, oh, well, I've just got all the data from our medicines information department. Do you want me to send it to you in the report I've written for our trust? So along I sent it to him, and then together we produced this paper for BIFA, which is part of BAPEN, to talk about actually that it's in our patient cohort, it's safe, it's still safe, and to give some recommendations just to maintain patient safety as well. And this was then used to send to GPs who were maybe a bit scared to prescribe loperamide after that alert came out. So just to let you know that if you are having doses above 8 milligrams in a 24-hour period, the data has been looked into for patients who've been prescribed it for conditions to help thicken their stools or thicken their stoma outputs. And there are recommendations in place, and this has been distributed to all prescribers, so people will be monitoring you just to make sure you're safe. So please don't worry about that if you ever see it on your packet. And that was basically the principle of the story. And I could have said that in one slide, but I thought I'd take you on a journey with me. Let's go on to other ones. I know this is quite controversial, but we've got a dietitian in the audience who'll be doing a talk, so she'll go into more detail about this. Vitamin B Co12. The absorption is in the last part of your small bowel. So the part that's found very close to your colon, which is on the right at the other end of the picture. So because a lot of patients with pouches or altered GI anatomy might not have that small part, that last part of their small bowel, we would give you the injection intramuscularly. So there's no point giving it orally because we know it won't absorb because that area is not there or has been altered in some way, shape or form. And it's 1 milligram every 1 to 3 months, and it tends to be from the GP or in some cases from hospitals. And initially you'll be loaded, so you'll have more doses frequently, and then you'll go to every 3 months. And folic acid also might be added as well. And the main reason why we do that is to help avoid things like anemia, because you need folic acid and thiamine to help produce your blood cells, red blood cells, amongst many other things. Now, and I know the controversy is a little bit about the tests, and the tests that we carry out in the NHS at the moment, it's serum vitamin B12 is the standard test. And there are other tests that will look at a more active form, but they're not readily available on the NHS. So a lot of NHS providers have been asked that if you know somebody who is symptomatic and having symptoms of vitamin B12 deficiency, and you're seeing that their serum vitamin B12 is within range, maybe consider taking the 2 pictures into consideration and still prescribing them the vitamin B12 and monitoring them and taking the patient into whole. So for instance, if I had a pouch patient who didn't have a terminal ileum, their vitamin B12 was in range, but they were symptomatic, we'd probably give it. So we've been asked to take that into consideration. Vitamin D is another one that we struggle with. The absorption is in the jejunum. So if you have a poor quality jejunum, and we don't have a lot of jejunum, and that's the section of the small bowel that was closer to your stomach, we can give you oral preparations. The oral is quite well absorbed from the bowel, or we can give you intramuscular if needed. And the intramuscular tends to be, again, from the GP or the hospital. And we would monitor both your vitamin D and your B12 levels every 3 months, roughly. And the monitoring can be done by your GP. And sometimes as well, we might ask patients with pouches or stomas to take a complete vitamin or complete vitamin or mineral preparation just to support any vitamins that you might become deficient of. We have pouchitis. This is a protocol, one of the protocols we use in St. Mark's. The main antibiotics that you'll see are ciprofloxacin. For ciprofloxacin, you might have to be cautious because it can impair skilled tasks. And you've got to be careful when you take it with certain oral antacids, calcium, zinc, and iron preparations, and also dairy preparations, because it can bind the ciprofloxacin and prevent it from being absorbed or being utilised in the or being available in your pouch area. With metronidazole, the main caution there is to avoid alcohol consumption while you're on it and for 5 days after stopping. Tinidazole, it's from the same family as metronidazole, so again, it's the caution with alcohol consumption. And rifaximin, it's one of the newer ones that we use, and the main action is in the GI tract, and it's got very little absorption, so that's a great one to use. So that's why we kind of leave that for a last-line therapy. When talking about antibiotics, you've probably heard about antibiotic campaigns and stewardships. Well, it's very real, and we are seeing a lot of drug resistance, bugs that have been grown in our patients here in England. So we've all got to be careful with our antibiotic stewardship. So just some reminders about how to take antibiotics, take regularly, take at the same time each day, ensure the timing fits around with your lifestyle. So for instance, if you're working shifts, you might be counselled to take it at lunch, dinner and evening, but just make sure it works for you and your lifestyle. I recently had to take a course of antibiotics 3 times a day. It was a complete nightmare. I had some on my bedside table, I had some at work, I had some in my handbag, I had some on my dining room table just to make sure I took them all. Don't miss your doses. Even if you're feeling better, it's very, very important you complete the course, and that's just to avoid antimicrobial resistance or relapse. And if you do get one of those two, it could lead to an escalation in your therapy, which we want to avoid. Probiotics, I put this on here just to let you know that it's no longer available for prescription on the NHS, or whether that be GPs or in hospital, but you can buy it from your pharmacies and your local food stores. Prescription costs, the cost for one item at the moment is roughly about £10. And one item is if you have the same drug, strength and formulation. So for instance, you can get 3 months supply of one drug and that will cost you roughly £10. And you'll get charged that in your local pharmacies as well as your hospital pharmacies as well. So outpatient prescriptions are chargeable in hospital. Who's exempt? There are a number of indications for exemption, and one of them is a permanent fistula. But what about other conditions that require regular medication that doesn't fall into an exemption? You can consider things such as prepayment cards, and these are prescription prepayment certificates. You can get them in your local pharmacies, your GPs, online, or by the telephone as well. So if you wanted to do a 12-month one, you can also pay by direct debit as well. You don't have to pay the costs up front. And here are the prices here. So for 3 months is about £32. For 12 months is £114. And I worked that out. If you have more than 2 medications, each you're collecting it at least 3 months, it's cost effective to do that. And you can do a direct debit that comes out of your account every month. And then also as well, for anybody who is on... Oh, there you are. It's just winking at me. If anybody's on HRT, there is a cheaper rate for HRT over 12 months. So that's really worth it. I told one of my neighbours about it the other day, and she bought me some flowers, and I said, well, I think you've just spent the money you would have saved, but thank you, they're gorgeous. So other prescription-only medications, I've listed them there. I'll just run through them quickly. So again, because it's such a wide group and such a heterogeneous group, I wasn't able to put everything in, but things like amitriptyline, it can be used for pain, depression, for epilepsy as well, can make you feel a bit drowsy. Paracetamol, be careful if somebody tries to prescribe you a combination of codeine and paracetamol again. Steroids, if you are prescribed steroids on a regular basis, make sure you have your steroid card, and any prescriber that you're going to see, just give them the steroid card, and that should have all of the information on there, and they'll be able to prescribe or look after you or monitor you appropriately, even if you're going to see the dentist as well, or you're buying anything from your local pharmacy, please make them aware. Azathioprine and mercaptopurine, you should have regular monitoring for that, and if you're prescribed that and you're not, please come talk to me afterwards. Biologic drug therapies, those are mainly managed by hospitals, and again, that takes regular monitoring. I'll just skip to diarrhea and St. Mark's solution. I know there's a national shortage at the moment of some of the ingredients used to make up St. Mark's solution, and some people are struggling to get hold of diarrhea as well. But if you speak to the centre that prescribes it to you, there's a document about to be published, again by Jeremy Nightingale, Biffa and Baypen, to give people alternatives on what to prescribe. So, cholestyramine and cholesevelam, if you're prescribed that, again, just like with the milk combined to the ciprofloxacin and reduces absorption, cholestyramine and cholesevelam bind to other drugs and reduce their absorption. So if you need to time them in a certain way with your other medication. If you're on it and you're not, and you haven't been explained about the timing, come and speak to me afterwards and I'll help you time your medication. And pancreatic enzyme replacements such as Creon. Again, there's a national shortage, but there's been really good guidance produced by the NHS. So if you are experiencing shortages of that or struggling to get hold of it, please speak to your centre, because there's now a national programme to make sure that everybody can get hold of it. Other forms of medication that you'll see, over-the-counter medications, are these things that you can buy, no prescription needed, so you can pick up from your local supermarket. There are pharmacy-only medications that you have to physically buy under the supervision of a pharmacist, and there's general sales lists. And again, you can pick that up from anywhere, even like your local gas station. So because all of those medications are available freely to the general public, I always feel it's important to educate this patient cohort, because of your bowels are just slightly different, and because we talked about that absorption in the beginning of your talk, So I managed to find some data that looked at the sales of over-the-counter medication in 2020. That's the most recent data I could find. And so I just want to talk you through the top few to give you hints and tips regarding your condition. So for pain relief, just be careful, because if you are requiring more pain relief or buying pain relief on a regular basis from your pharmacies, is your condition worsening? Is there anything that you need to have reviewed by your team? And also as well, things like NSAIDs, so ibuprofen, be cautious with, because they can cause irritation to pouches and to any stomas. With vitamins and minerals and anti-tiredness medication, do you have a deficiency? Do you need to get your vitamin B12 checked? Do you need to have vitamin B12 injections? So if you're experiencing, you're going to your pharmacy to buy that, stop and consider. Coughs, colds and sore throats, those can lead on or can be systemic of an infection going on, and I know our patient cohort are more likely to get infections. So do you have an infection? Have you checked your temperature? Do you need to go and see your GP? Do you need to contact your team for further support? Gastrointestinal remedies that were sold, again, is there something going on? Monitor yourself. If it's not improving, reach out to your teams, reach out to your GP. And skin conditions, I know a lot of people might have inflammatory bowel disease. Is this a manifestation of your inflammatory bowel disease? If it's not going away, you're repeatedly going back to your local pharmacies to buy things. Do you need to contact your team for further advice? And again, this is just my plea: avoid ibuprofen and diclofenac. So just quickly, I'll talk you through pregnancy and breastfeeding. This is a very, it's an area that can be managed very well, but you need to weigh up your benefits and risks, and your medical teams can help you with that. Safety data, there's no clinical trials because of ethical issues. There are lots of animal studies, but sometimes these are hard to apply to human models, and many factors may need to be taken into consideration when you're doing that reverse application. So we use general and basic pharmacology principles. We look at the patient's condition and progression, and healthcare professionals will help you make the right choice about what medication to prescribe during pregnancy and breastfeeding. So if please, just to reach out. Where to find information? You've got the patient information leaflets that are found inside the boxes of the medications. You've got your doctors, nurses, pharmacists, dietitians, And each hospital that you work with, they will have something called a medicines information team, and they have lines for patients to call up and ask questions directly to a group of specialist pharmacists who will give you proper, good quality information. Online, again, as Gordon said, be very careful online and only use NHS-approved sites when you're getting information. And there's also this support charities, and you're all here today, so you know about the IA group. And thank you for listening.